This section reviews some of the insights made about diagnosis in the social sciences, as they offer an alternative way of thinking about diagnostic developments and the management of disease in global health. Early medical sociologists such as Elliot Friedson and Talcott Parsons were interested in diagnosis because of what it revealed about medicine as a social system. They saw diagnosis as central to the structure and functioning of this system, separating the layman from the medical profession and the sick from the healthy, and signifying socially agreed or normative ways of behaving according to those roles. From this has followed a long history of the sociology of medicine, which has emphasized the social and moral context of identifying diseases and putting labels on symptoms or conditions. Much of this work has effectively rejected the notion of an underlying cause, showing instead the work that goes into creating and constituting diseases. Sociologists of diagnosis have shown how diagnostic categories are as much social, moral, and normative constructions as they are objective health conditions. Scholars have examined how definitions of medical conditions shift over time or how they differ between people or cultures. Some famous examples being homosexuality, which was defined as a mental disorder by the American Psychiatric Association and included in their diagnostic manual until 1973, Gulf War syndrome, which was denied by governments and militaries in the face of symptoms reported by ex-soldiers, and a more recent example is obesity, which has been associated with a range of often very personal social and moral values, but is increasingly labelled as a disease and even as an epidemic. Steeped in the sociological themes of social construction, social control, and identity, this body of work has shown the variety of ways disease labels can be used to legitimize or delegitimize patients' illness experiences, to access or deny treatment and other resources such as pensions or compensation, to extend medical authority by repackaging previously non-medical feelings or experiences as medical ones, to create diseases so as to open up markets for pharmaceutical products, or to control, marginalize, and stigmatize groups by establishing deviance or abnormality and turning that into medical pathology. More positively, diagnostic classifications have been used to empower patients, to create positive identities, and to challenge authority and demand equity. In these examples, we see that political and economic concerns are often part and parcel of what is officially sanctioned or deemed to be morally acceptable and normal. This work has been an eye-opening check on medical practice. However, many of the examples in this literature are of particular kinds of contested conditions, often concerning mental health, where biological mechanisms are unproven or unprovable. Receiving less attention are diseases with identifiable pathogens, which risks the implication that they are in some way less open to contestation. This ignores some powerful examples from diseases which have identifiable pathogens. For example, there are well-documented controversies over understandings of HIV and AIDS and the links between them. Scholars have pointed to the layers of social and symbolic meanings involved in HIV, AIDS, biomedicine, and science. For example, how assumptions about homosexual men's behaviour were institutionalised in medical understandings of risk factors for HIV transmission, and how that downplayed or overlooked infection pathways related to women or heterosexual behaviour. This has also become a factor with the diagnostic profile of AIDS, as the collection of opportunistic infections recognised as AIDS-defining illnesses was skewed towards problems observed in men, homosexuals, and intravenous drug users, and not those common in women more generally. The example of HIV and AIDS highlights how social factors not only shape, but go right to the core of biomedicine. It also highlights the needs for another perspective on diagnosis, which shifts the focus from an interest in labels and classifications towards an interest in the process of diagnosis. Diagnosis can be understood not just as a one-off event, a clinical moment, but a recognition process in which a disease or an illness come to be understood. And this can happen at the level of a disease unfolding in an individual patient or within a society. When diagnosis is examined as a process, the knowledge and technology used to define the disease become important. Medical historians such as Charles Rosenberg have studied how modern biomedical framings of disease have emerged. Rosenberg charts the advent of biomedicine by showing how increasingly specific conceptualizations of disease replaced the fluid, transient, and individualized manifestations of symptom-based humoral medicine. It was these developments, he argues, which propelled diagnosis to occupy such an influential place in modern medical practice. Diseases began to be identified by unique characteristics and treated in a specialized manner. Technological innovation played a part as new tools, which he described as instruments of precision, helped doctors to measure these unique characteristics, boosting what he calls a specificity revolution. By the 21st century, disease was defined more by accounts produced by these precision instruments than by the narrative of the patient, and disease was imagined as an entity independent of the patient. Ideal typical models of both diseases and bodies were developed. These models had characteristic mechanisms which could be objectively captured by measurements and investigations. The underlying assumption, Rosenberg points out, is that stable and specific disease entities were the cause of illness. These specific disease entities have since become a critical cog in medical practice and are the basis of healthcare systems, hospital administration, and a range of associated bureaucratic institutions, as well as a considerable amount of moral and social order. Expectations of molecular diagnostics are rooted in their potential to be rapid and mobile, as well as to achieve high levels of accuracy. As such, they appear to be continuing the documented trend from symptom-based medicine to specific disease-based medicine, enabled by technology which can reach new levels of specificity to detect antibodies, strains of DNA, and viral proteins. As this trend in medical thought and scientific innovation gathers pace, what are the alternative views or factors which are being obscured as certain models of disease and diagnosis gain prominence? Or which views and conditions are emerging despite the pressure to focus on viral proteins? The rollout of diagnostics is revealing unexpected dimensions to diseases and to understandings of the role of diagnostics in the process of diagnosis. For example, while on the one hand there is a pressure to test and treat, the increased testing is producing test results which do not correlate to symptoms and are the source of increased clinical ambiguity. In the case of sleeping sickness, it is often not clear whether a positive molecular test indicates a current infection or whether infection always leads to disease. For malaria, it has long been known that people can harbour the parasite without having a clinical case of the disease. But the expansion of testing is also revealing considerable numbers of fevers which would once have been classified as malaria, but which are actually negative on tests. The category of non-malarial febrile illnesses is now increasingly common as scientists work to identify these mystery fevers. Yet for health workers, this absent or vague diagnosis is problematic, and studies show that people who test negative for malaria are often treated with antimalarials anyway. These examples complicate some of the expectations surrounding new diagnostics. Instead of making diagnosis less presumptive and making medicine more orderly and less uncertain, there is evidence of the opposite, that actually new diagnostics are implicated in a medicine which is increasingly complex. This has significant implications for disease control and the clinical management of disease. In the next section, we will look more closely at emerging zoonotic diseases to see how some of these themes play out.